All right, guys, I just want to go through the ID case quickly. I'll post the key Word document as well so you can review that, but I'll just, whoops. All right, apparently I have like 20 minutes before my computer's going to shut down on me, so we'll get it done. Here we go. So you've got a patient here, and everything's pretty straightforward. I gave you enough information to pretty much guide you into the fact that this would be a CAP case. And then I gave you some outpatient susceptibilities for Streptococcus pneumoniae. This is actually how it would show up on our antibiogram, so that's why I gave you those choices. Some of them may be confusing. I did get an email about the penicillin IV non-meningitis. That would be for some specific cases only. You would never really use that for pneumonia just because empirically it's just not good enough coverage, even though you know it's susceptible. But some like anti-staphylococcal penicillins, such as amoxicillin, might be okay. We just don't use penicillin for that. So you have a patient here, and your assessments, again, CAP, and I gave you that this was going to be, for the first part, as an outpatient treatment. So that's the direction we're going. But just to review a little bit, you can look at the justification. So if you're going to discharge somebody, they should be hemodynamically stable, low-grade fever only, and be relatively healthy. Usually the pneumococcal urine antigen isn't usually something that's done in clinical practice, but I gave it to you just for the sake of doing it, leading you to suspect strep pneumo as a likely microbial culprit. However, you don't necessarily know that for sure, even with the antigen. So considerations here. You have two treatment options in this patient's case. One is respiratory fluoroquinolone, so Levaquin or moxifloxacin. And again, we usually pick Levaquin as our CAP drug of choice just because it has a shorter course of treatment. It's generic and less expensive generally than moxifloxacin. The other choice you have is azithromycin plus some sort of beta-lactam. So I like ceftonir as a third-generation cephalosporin. If you like, empirically, it's got very good coverage against strep pneumo. With the azithromycin, you can do the Z-Pak dosing to cover atypicals. Other things are okay, and even like high dose amoxicillin or augmentin would be acceptable as well. And again, I just wanted to make it clear that even if the strep pneumo antigen is positive, you can't necessarily rule out atypical, so you wouldn't want to treat with like just ceftonir. You'd be missing it. However, I will give the caveat that in Europe, they tend to ignore, at least in England, they tend to ignore atypical pathogens and focus mostly on the strep pneumo alone. Incorrect choices, azithromycin, your local strep susceptibility is poor, so you know that even if I didn't give you the urine antigen, you would still want to cover strep pneumo. So we want to ignore azithromycin as a monotherapy. It's not a correct choice. Doxycycline, just because he has hives to tetracycline in the past, which is in the same class, you'd want to consider that to be a severe enough reaction to rule this out. Hives and anaphylaxis-like reactions are usually severe enough hypersensitivities that we don't try drugs in those classes. Follow-up, consider instructing the patient to contact you or seek emergency urgent care if he doesn't improve, of course, and then follow up with the patient on your own in a couple of days, see how the treatment plan is going. Part 2, I've got this patient who comes back to the emergency department. So he only took his antibiotics for 2 days, felt a little better, read online that the antibiotic could cause tendon pain, which he didn't like, so he stopped taking it. And so he comes back in. He's not doing great. His respiratory sats are low. He's on BiPAP already, which isn't a good sign. And you get a sputum sample. You send it to the lab. The same patient, so same allergies and social history apply. I won't go over that again. Labs and vitals are there. He's got tachycardia. His blood pressure is down, and his temperature is elevated. His CBC is normal except for white blood cells elevated. So basically, I gave you all the standard inflammatory markers you might see. I didn't give you a lactate, but you have everything else to really pretty much rule this in as a septic patient. So he's looking septic. He's got the hemodynamics, again, likely source of infection, elevated white blood cell count, and he's febrile. Sputum gram stain, you can have that there. Gram-positive cocci, gram-negative bacilli, could be normal respiratory flora, could represent a polymicrobial infection. I said in class sputum stains and cultures are tricky because you can grow a bunch of stuff that's not even a pathogen potentially. It could just be stuff in the mouth or the throat and not really anything we're technically concerned about, but it also could be pathogenic. So what we're looking for maybe would be something like Staph aureus or I don't know, Pseudomonas, something we wouldn't expect to see as normal flora. Again, you got to take some of what you see with the sputum culture as a grain of salt. That's why they aren't done a lot in clinical practice, because you don't really get great results with them. Consideration for treatment. So we're a little bit more challenged. This guy started Levaquin and stopped it. Now he's septic. So because he's septic, that automatically puts him into broad spectrum antibiotic, the broad spectrum antibiotic treatment group. You could make the argument that, well, we know it's a pulmonary source and we know it's likely community-acquired pneumonia that wasn't treated well, so maybe could we just continue something for CAP, like a basic CAP treatment, or maybe even an IV CAP, like we could do IV ceftriaxone or zithromycin. And that's not a bad thought process, and I have seen that done occasionally in practice where we have somebody come in, physician's pretty confident in the source, and even though they're septic, they will treat that way. It's not necessarily the best based on the evidence we have to support sepsis treatment. However, it's not necessarily wrong either. It's a bit of a gray area. But for this class, when you think sepsis, I want you to think broad spectrum. And I want you to think that way in practice too. So with broad spectrum antibiotics, you want to cover MRSA. You also want to cover zosyn, cefepime, and cover your gram negatives with a broad spectrum agent too. So zosyn, cefepime, or carbapenem would work. IV azithromycin would probably be still relevant here because this person started with community-acquired pneumonia. They didn't take a full course of the treatment, whatever you gave them. So if there was an atypical pathogen, theoretically it could be sticking around still. So I would add IV azithromycin on board here. And your sputum culture, again, if it comes back, we can watch it and maybe narrow. But for now, this is our broad spectrum approach. Again, restarting Levaquin IV is just too sick for that at this time. You want to give something a little bit stronger, and he didn't finish his course, so you could possibly be looking at resistance to whatever you're treating. And then, again, I talked about ceftriaxone and azithromycin IV as being an option, but and it could be okay in some cases. This guy's ill enough where, again, I would go with the sepsis criteria and treat broad spectrum. This guy's probably going to go to the hospital. Might go to the ICU depending, and if his O2 sats continue to decline, his respiratory problems aren't resolving, you might consider advanced airway like intubation. Okay, so we admitted him to the hospital. 2 days later, we get a sputum culture with mixed respiratory flora, but we did get the following pathogen that came out. So we got Staph aureus, and then here are the following sensitivities to it. So if TF is improving, what would you change about his antibiotic therapy at this time, and are there any oral therapies that could be used? So at this point, the guy's improving, and you can assume he's still on his broad spectrum antibiotics that you started in the second part of the case, and now you need to figure out how do you work with this information? What do you do with this new information you have? Do you do anything at all? And then start looking at discharge options too. So with this resistance pattern, you should look at this as MRSA. So it's Staph aureus, and the big key on any lab report is going to be oxacillin resistance. Even though we call it methicillin resistance, you never really see methicillin pop up. Oxacillin is usually the one that they do sensitivities on. And again, these are products made by companies designed to treat for multiple antibiotics at once. So oxacillin is a pretty standard one. If it's oxacillin resistant, MRSA. Ancef resistance is usually a sign of MRSA too. So either one of those, cefazolin or oxacillin, that's a giveaway. So what do we have as option? We have tetracycline, which is susceptible, vancomycin, and sulfamethoxyl trimethoprim. Hopefully you, because of your septic patient previously, hopefully you decided to start vanco on him. If you didn't, now would probably be a good time. But we can talk about some of the other options here too. So what I would say is that you need to tailor your antibiotic at this point. And to do that, Your broad spectrum gram-negative agent probably isn't all that relevant anymore. Zosyn, cefepime, and carbapenem, or whatever you picked for that, doesn't really matter anymore, but it's not going to really be necessary. We don't need it because MRSAs are likely pathogen that I'm giving you here. All right, so we can continue your IV vancomycin for now. If you wanted to, that would be a good option, and then switch to oral therapy in 1 to 2 days if the patient continued to improve. The IV vanco is likely what's contributing to the patient's recovery. And then you're looking at oral therapy. Well, before I talk about oral therapy, I'll just point out that doesn't become a black and white thing. It's not like as soon as you get the cultures back, you can say, okay, it's vanco, good to go. Most of the time, that is what we do. We say, okay, the culture's back, let's get rid of what we don't need and quit exposing the patient to antibiotics unnecessarily. However, there are some cases where even though you have culture results, you may still be thinking it might be something else. So maybe you're thinking there's something else on the culture that you aren't seeing or something that's not growing out. You might have suspicions that, I don't know, this wouldn't apply to this case, but maybe in a pulmonary infection situation, the patient may have aspirated some GI contents. And so if it's GI contents, that could be anaerobes. So they might want to cover for anaerobes. Anaerobes are very difficult to culture. So there's lots of reasons why you might not want to narrow therapy, but generally speaking, we do go with following the cultures and we narrow therapy as we can and tailor those antibiotics appropriately. Okay, so choices. Again, we talked about continuing the vanco, which is probably the easiest one to do. Now, what you could do at this point, theoretically, if the patient's doing well, oral Bactrim or sulfamethoxyl trimethoprim up here in our resistances, that drug gets into, oops, it's already bold, I guess. That drug gets into the pulmonary tissue pretty well. You could use it for a pulmonary infection. That's something we could consider switching to immediately, potentially. Don't get tempted by the tetracycline. I put that in here to trick you guys because remember, he is allergic to that, even though it's back in part 1 of the case, but still, allergies still apply. Watch out for that one. You're not going to use oral doxycycline. So you can really do, geez, my computer just needs updates apparently, crap. So you can really just do one of 2 strategies, I think. Continue the vanco for another couple days, 1 or 2 days, and then see if he improves, switch him to oral Bactrim, or switch him to oral Bactrim immediately. It just depends on how comfortable you are. I probably didn't give you enough information to really make that decision, and that's okay. In a test situation, it's not going to be that complicated. This case is designed to be a bit more broad and have a lot of different ways you could come to the same conclusions potentially. My test questions are a little bit more clear-cut, but this is the kind of thinking and types of problems I want you to be considering as you're studying, and hopefully this was helpful. If you have any questions about it, feel free to email me. Otherwise, it's posted, and so enjoy it as you see fit.